Hi everybody, my name is Rikkert. I'm from Logix, and I'm going to tell you a little bit about how we turn data into to better healthcare at Logix. But before we start, a little bit about myself. I've been working for Logix for over 8 years, and I'm responsible for one of our business units in Europe. And over that time, over those 8 years, I've seen a lot of healthcare providers, and we've supported them on a variety of topics, from financial questions to outcome registries to discussions with payers. And my background is in finance and economics. I studied in Rotterdam at the Erasmus University, and also studied in Madrid and did my master's actually here in the UK at Warwick. And before we start, maybe a little bit about Logix. So we are active in the Nordics, in the UK, and in the Netherlands. And so we're active in one of the most advanced healthcare markets in the world. But apart from the UK, of course, also some of the smallest markets in the world, and that's also the reason that I'm sitting here. We think we've built something beautiful over the last 10 years, which we think that other countries and other clients should also get to know. We employ over 300 people, and half of those are technical people, because we build software, of course. So that's database, front end developers, and the other half approximately are people like me, consultants who are implementing the products and having the interactions with clients ongoing. Why do we think healthcare is such an exciting industry to be active in? Well, one reason is that there's happening a lot, and what you see on the left is that healthcare cost is growing like super rapidly, and for example in the Netherlands, but this accounts for actually a lot of the Western world. If we wouldn't do anything from 2020 to 2040, our expenditure on healthcare relative to GDP would almost double. And that's of course unsustainable and unaffordable, because I also want my kids to receive education, and paying even more tax is also not something that we really want, probably given the current tax rates already in the Netherlands. So if you think about that sort of big problem, then it's clear that something needs to happen. We need to, and we also have, by the way, an aging population, of course. So we get more and more people into our healthcare system. So what can we do about it? Well, there are many things we can do, but you could think in sort of 3 improvement dynamics. And the easiest one is that we say, if we can keep delivering the same quality and the same quantity of care, but against a lower cost, then at least we're flattening that curve already a little bit. But then the question is, will that actually be enough? And then that's why we have a second improvement dynamic, and that's more about if we can improve the quality and the outcomes and make different decisions, such that we don't do that surgery with the patient, or we try to keep patients within the primary care setting, for example. Then that's also a great thing to achieve, which can also affect cost. And of course, the best is that that we do all of these things at the same time to flatten that curve as much as possible. Well, luckily we have a lot of data. There are some starting points for us, and there are quite many, but this is just an interesting one. Is that we see that there's a widespread variation in outcomes and medical practices. And for example, in some trusts, the complication ratio can be 13 times as high as another trust, or you can even be that the mortality rate is higher. And imagine you're a patient, and this information is usually not available. That you're in one of these hospitals, you don't want to be there, of course, and you don't want that these complication ratios are so different. And this is in the Netherlands, where I think the average level of healthcare is really high, but it's also it doesn't even matter that much to which provider or which clinician you're going. And still we see a lot of variation. And on the right hand side we have gallbladder surgeries, for example, and you see that in some regions in the Netherlands, the risk or the chance of getting a surgery is so much higher, which you can't really explain by by demographic factors, that people are older or have a lower socioeconomic status. There must be something else at work over there, and that's of course very interesting to know, but also to make those providers aware of what's actually happening. And that's something that the British Medical Journal worked on. They did a study, what you see on the left side, and they've shown that there's a significant portion of healthcare which is, of course, and luckily it's proven or presumably effective. There's also quite a big chunk which is proven or presumably ineffective, so that's already quite worrying. And then there's a very large chunk which we don't know. And one clinician once said to me, but Rikkert, jumping out of a plane with a parachute, gives a better chance of survival than without a parachute. So, why should we test it? So that's probably also at play, that some of those treatments are perhaps in the gray area. But this, of course, is a worrying signal, but it also gives the opportunity, because that means that there's something we can do and we can change. And that's basically is we want to approach healthcare from different segments, and in the spirit of value-based healthcare, as for example defined by Michael Porter from Harvard, we want to look at it from all aspects. So we want to look at it from a financial domain. So how do we organize a healthcare provider, for example, an acute trust, in the best way possible, that we deliver our care as cost effectively as possible. All the way on the other side, we want to create the best possible outcomes, and one way of doing that is by registering what those outcomes are and what you do in your process, because that will give insights, and those insights can lead to changes. And then the holy grail within healthcare is to get better outcomes against those lower costs, and that's what we try to achieve in the value domain. And what we see happening there, that this is also something that needs to be promoted by payers or by countries, that providers are also reimbursed on value. So if you provide better treatments with higher survival rates or less complications, then there should be something in for the provider. But how to organize that is still quite difficult. So that's still relatively a greenfield. And doing all that work, so does it add up to something? And then I would say significantly, of course, but I'm not completely objective. But it is a real world data example. This is the collateral surgery. It's one of the most it's one of the most successful registries in the Netherlands. And what's been achieved there, and this is already data from 2017, but only in a few years, complications for this type of surgery went down with 11%, which is already a great thing. But at the same time, we also saw that cost was reduced by over 25%, and that's almost 4,000 euros per patient. So that has a significant impact if you think about how many people get this surgery, and this has been done for a lot of treatments already. And that's also the reason that ICHOM, which is the institute which basically creates these registries and these standards to compare health outcomes for providers, that they've chosen us to set up with them a global benchmarking platform to basically allow any provider in the world to compare their processes and their results to other peers within their country or even internationally. So we're very proud to work together with them and export this to other countries. Is there any magic that we've learned over the last 10 years? I think so. And one of the most important ones is that we really try to involve clinicians. And the reason that we do that is that we think they are one of the most important assets of a healthcare provider, because as a patient, when you come into the hospital, the clinician will decide what treatment will we do. Will we go for surgery, or will we first do a therapy and then maybe a more minimal invasive surgery, and what kind of diagnostics is required? And on the right hand side, it's meant in a funny way, but there have been studies, for example, that younger doctors who are a little bit less, maybe perhaps you should say secure, that they do much more MRIs but also lab tests, because they want that confirmation of what they probably think is going on, if that's actually the case. And that's of course driving up cost in the system. So by making all these decisions, they are of course very much influencing the total cost of a patient, of a provider, of a system. So we think they really deserve the information on how they're doing and how their decisions compare to basically their peers. And that's our most important asset, is that we provide benchmarking type of data to register, how to register, etc. There's quite some standardization ongoing that really allows well for benchmarking, and we've seen that this is a super powerful tool to compare departments, compare providers, but also compare clinicians. And they really actually like this and are motivated to understand, where they're taking a different route. And if there's a better route, we have experienced that they are always keen to go that way, because ultimately their drive is to help patients in the best way possible. And the best way possible can or quite often also coincides with the cheapest way possible. That's what I wanted to talk about. And why am I here at that Northernlands3 event is we think that the Netherlands has something beautiful with respect to their healthcare. We have a great system which is functioning really well. There's very good access to healthcare. If you want an appointment, you get it really soon. There are not a lot of long waiting lists. It's still relatively affordable. It's a very productive system, and the Euro Consumer Health Index also recognized. And I think many countries in Europe, but also outside of Europe, are keen to learn from the Netherlands how we've done that. We as Logix would also like to export that beautiful thing, healthcare, to other countries, and to allow other countries to get much more insights from their data. Thank you very much, and looking forward to see you in the Q&A.
Thanks, Rikkert. That was fantastic to hear, and it's great to hear someone from the Netherlands as part of the Northernlands.
Thanks for having me.
Yeah, and you just asked whether there would be a Northernlands 4. We think so. Northernlands started off as an in-person event here in Leeds, and we were supposed to do a reciprocal event over in the Netherlands, and that never quite happened because of things. So we're looking forward to Northernlands 4 being an in-person event, so it would be great to meet you in person there, whether it's in the UK or in the Netherlands. Let's see. But I guess one of the questions is from your point of view, what do you see the differences and the similarities between the UK context and the Netherlands?
Thanks for that question. So I've been working in the UK now for almost 2 years, partly remotely from the Netherlands, but also often in London. And what we've noticed from a sort of a healthcare system setting is that we really see the move towards integrated care systems, and there's discussions coming up more frequently. And that's actually quite an interesting model, which we've seen also in the Nordics, so in Sweden, Norway, Finland, where all data is available on a regional level, and in the UK with the NHS number, etc. That's actually quite well organized, and that region will divide the funds over primary care, secondary care, elderly care, and I think that's a very important factor, because that will ultimately determine how we get the change in the system towards more conservative treatments and trying to keep patients more perhaps in primary care and not as fast in the acute care, to also sort of create the room and space there for the extra people that will flow in due to the demographic change. So that's what we really see happening right now, and those discussions are ongoing, and we see that, for example, providers in one ICS are really trying to move to similar software partners to set up a data architecture. And if we compare that to the Netherlands, for example, in the Netherlands it's quite difficult to do that because it's very siloed. So primary care and secondary acute care is completely separated. So we cannot, even though we would like to, it's very hard to connect the data because it's completely different data systems, and we only have claims data which could do that. So that's your sort of data architecture is quite important there.
And what's so important to us is obviously being open. Are you seeing more open source, more open approaches, more open innovation happening in the UK compared to Netherlands, or vice versa?
Ooh, difficult question, to be honest. I don't see it happening a lot in any case. Working, of course, with personal data, so that's quite tricky. But one of the things where we're actually applying this is we've recently announced a collaboration with ICHOM. That's the International Consortium for Health Outcome Measures. It's a US-based company. It's founded by Michael Porter, and they're creating standard sets which you can apply all over the world. Like, what are the metrics you need to implement to determine if a intervention or a surgery was successful? And what we're going to do with them is we're going to create the benchmarking platform such that we can compare data, and it's going to be anonymized, and then we allow other parties to go on the platform and create analytics reports, etc. So that's actually quite an example of an open data system. But we don't see it happening a lot yet, unfortunately, because
Well, I'll keep doing this. This is my badge, which says Open Data Saves Lives, and we'll be hearing a bit more about that later on. But if you want to join in with it, find us on the web at opendatasaveslives.org, and please do join in with the innovation that we're doing there. The last thing I'd like to ask you is so what are the opportunities, and what do you see happening next for you?
Yeah, so the UK is an important market for us because we're quite big in the smallest markets of Europe and the world probably. And one of our mottos is impact you can measure. But then of course we want to have more people, more countries benefit from our approach. So in that perspective, the UK is important, and we're really trying to roll out our platform because we think there's huge opportunity in leveraging existing data. So it's not so much about generating new amounts of data, because there's so much already which is unused, and that's what we're really trying to look at, and to get that data with clinicians, because that's what we see in the NHS, that it's quite hard to get them involved. But ultimately a clinician decides when can a patient go home, what treatment are we gonna go for, and if we don't get their involvement, then it's very hard to realize change, we think.
Fantastic. Thanks, Rikkert. You should come to Leeds, because there's that's where health data gets done a lot.
I'll take on that invitation. I'll definitely come over.
Fantastic.
Great.
So thanks very much.